A woman arrives at term saying her waters have broken, and there is a strong pull to jump straight to the question everyone finds interesting. Do we induce her now, or do we wait? That question can wait. The first hour has two quieter jobs, and getting them right is what makes the induce or wait decision safe to have at all. The first job is to confirm that the membranes are actually open, and to confirm it in a way that does not seed the very infection you would then spend the next day fighting. The second is to sweep for a short list of findings that take the induce or wait question off the table entirely. Name the branch before you start any clock. Start with confirming rupture, because most of the time it is easier than the tests suggest. You put in a sterile speculum and you look. A pool of clear fluid sitting in the posterior fornix, or fluid trickling from the cervical os when she coughs or bears down. When you see that, you are finished. History of a gush and fluid you can see with your own eyes is the diagnosis, and no laboratory test will make it more certain. In the old series that worked this out, more than 8 in 10 women were diagnosed on that single finding. Fluid, visualized, coming from the os. The speculum carries so much of the work because the whole diagnosis lives in two places it shows you directly: the posterior fornix and the cervical os, and neither of them needs to be touched to be seen. The tests earn their place only when you look and you do not see a pool. Then you reach for one of the two old bedside tests, and you must know exactly how each one lies before you lean on it. The first is pH, the nitrazine paper. Amniotic fluid is alkaline, its pH sitting around 7, while the healthy vagina is acidic, closer to 4.5, and the paper swings to dark blue once the pH climbs past about 6.5. The trouble is that several other things are alkaline too. Blood is alkaline, semen is alkaline, bacterial vaginosis raises vaginal pH. So the nitrazine test calls rupture when there is none in roughly 1 woman in 6, a false positive rate near 17%. And in the other direction, a slow leak diluted by acidic vaginal fluid can read falsely negative about 1 time in 10. It is a test that is fooled by ordinary things you will meet all the time. The second bedside test is ferning, and it looks at first like the better one. You let a smear of the fluid dry on a slide, and amniotic fluid crystallizes into a delicate branching fern, driven by its sodium chloride. A positive fern is genuinely strong evidence. It is fooled only about 3 to 6 times in 100. So the natural thought is to trust ferning over nitrazine and be done. Ferning sensitivity, though, depends on who you are testing. In a woman already in labor, it catches rupture almost every time, around 98%. But in the woman who is not yet contracting, which is precisely the term prom woman standing in front of you at triage, its sensitivity falls to about half. A negative fern in a woman not in labor barely moves the probability of rupture at all. And the reason is mechanical. Ferning needs an estrogen-rich, chloride-rich sample that dries undisturbed. And before labor, the sample is scantier and more diluted, so the crystal simply fails to form. The test is weakest in exactly the pre-labor sample you most need it to read. Which is where the immunoassay comes in, the Amnisure test. It detects a protein called placental alpha microglobulin 1, present in amniotic fluid at concentrations far above anything in blood or normal vaginal secretions. And its validation numbers are dazzling. Sensitivity near 99%, specificity reported at essentially 100, a positive predictive value at 100. So why not simply swab everyone and skip the rest? Because those numbers were earned in clean, clear-cut cases. And the woman who makes you reach for the test is not a clear-cut case. In women with intact membranes, but the symptoms that mimic rupture, contractions, some bleeding, heavy discharge, the false positive rate climbs to somewhere between 1/5 and 1/3 of them. And the Food and Drug Administration has warned in plain language against relying on the test by itself. So the Amnisure test is a tiebreaker, brought out when the speculum has genuinely left you in doubt. It does not replace looking.
There is one examination you must not perform in this hour, and it is the one your hand reaches for out of habit, the digital vaginal exam. The finger, at this moment, is an intervention that raises infection, and the effect is large. In the secondary analyses of the large term prom cohort, infection climbed with the number of digital exams a woman received. Neonatal infection roughly doubled once she had 5 or 6 exams, and rose further to an odds ratio of about 2 1/3 at 7 or 8. Clinical chorioamnionitis rose more steeply still. Past 8 exams, the odds were more than 5 times higher. The mechanism is exactly what it looks like. The barrier that sealed the uterus is gone, and the examining finger drags the ordinary bacteria of the lower vagina up through an open cervix. Direct inoculation, and the seeding of a subclinical infection of the membranes that only later declares itself. The sharp objection to that is real, and you should raise it yourself. Those numbers are confounded. Longer, more difficult, already abnormal labors are the ones that get examined over and over. So maybe it is the troubled labor driving the infection, and the exams are just its marker. 2 things answer that. First, in Seward's multivariable models, the exam count survives adjustment. It stays an independent predictor after the length and character of labor are accounted for. But the cleaner answer is an older study from Wagner that isolates a single exam at the very beginning. Among women who received just 1 digital cervical examination at admission, 1 at the door before any labor had a chance to unfold, 5 of 18 babies became infected, 28% of them. Among the 78 women not examined at admission, not 1 baby was infected. 0. A single exam at hour 0 cannot be explained away by a long labor, because there was no long labor yet. That contrast is what holds the rule up, and we hold it up on that contrast because there has never been a randomized trial of a deliberate exam reduction strategy. The association, together with Wagner's admission exam finding, is the evidence we have. None of this means your hands are tied, because the things you actually need in the first hour do not require a finger. The speculum is fine. It never touches the cervix. The Group B strap swab is fine. You sample the lower vagina and then the rectum through the anal sphincter. And again, the cervix is never touched. So the whole first hour delivers everything. Rupture confirmed by sight, the GBS culture collected, the cervix and the presenting part assessed with your eyes, and no finger. The digital exam is simply deferred, held back until she is in active labor or you are committed to delivering her. And if the worry is that you need a Bishop score to plan the induction, the ripeness assessment can wait until you are genuinely starting that induction. The cervix will not have changed in the minutes you save, but the infection cost of the exam is paid the instant you perform it. There is even a fingerprint of this harm inside the induction trials you meet in the coming lectures. Where every woman was examined, the infection advantage of inducing early showed up most clearly, because the finger's damage was being done on both sides of the comparison. With rupture confirmed and the finger kept out of it, the second job of the hour begins, and it is triage. Before you start any induction clock, you sweep for the findings that change which branch you are on, because several of them settle the management before induce or wait is even a question. Look at the fluid. If it is stained with meconium, you now hold a fetal status concern that calls for continuous monitoring and a move toward delivery. If there is frank blood, you treat it as abruption until proven otherwise, and you deliver. Look at the presenting part, because with the membranes open, a high or unstable head or a non-cephalic lie means the cord can slip down and prolapse. So you assess the level and the stability of the head at the pelvic brim before a drop of oxytocin. And a baby who is not head down becomes a decision about the mode of delivery, not a candidate for routine induction. Ask her history.
A positive group B strep result is not by itself a reason to induce, but it commits you to intrapartum antibiotics and tilts the whole plan toward birth, enough that it earns its own lecture next. A prior cesarean turns this into a trial of labor after cesarean with ruptured membranes, where oxytocin carries a scar cost. It raises the risk of uterine rupture close to twofold, and that is a different induction conversation, held more carefully. A cervical cerclage still in place is a stitch that has to come out before labor is allowed to advance against it.
Grand multiparity is usually the fastest labor of all, with a second stage that can be a matter of minutes, but a real tale if these women slow down unexpectedly late, and precipitous labor is its own hazard to be ready for. And if she is not quite term, 34 to just under 37 weeks, she is on the late preterm boundary, where expectant management and immediate delivery are both defensible, and you are weighing the baby's risk of respiratory distress and ventilation against the mother's rising infection risk, which is an entirely different calculation from the one at term. So the first hour establishes two things and hands them to everything that follows: that the membranes are truly open, shown with the eye and the speculum, and never with the finger, and which branch you are standing on. Only when rupture is confirmed and no override flag is flying do you start the induction clock. Branch first, and then the clock.